Welcome to the Northwell Transplant Center. The purpose of this talk is to familiarize yourself with kidney transplantation. There are several options to treat kidney failure. It includes hemodialysis, peritoneal dialysis, and transplantation. Transplantation, as long as you qualify for the process, provides two main benefits. It provides a better survival, one is able to live longer, and a better quality of life, one is able to live better. It is, however, a complex process that requires a thorough evaluation and lifelong follow-up. Furthermore, you will need to take medications for life that we will be adjusting together with your referring nephrologist along the way. Please be aware that you will always be the patient of your referring nephrologist, and we will be working together to a greater or lesser extent along the way with them. Now, the first step in the transplant evaluation process is for you to be seen by all the members of the transplant team. Once this is achieved, if it is considered that you will tolerate the surgery without any major problems, we will continue with the evaluation. That includes drawing blood and having several tests performed. A test that we perform on everybody is a heart evaluation, which includes potentially an echocardiogram, a stress test, and in some cases a cardiac catheterization. Please be aware that although the two main benefits of transplantation are improved survival and a better quality of life, in order for you to undergo transplantation, you have to make sure that your body will tolerate it. Furthermore, your body, after we perform the transplant, will not be able to recognize the kidney as an organ that provides you a better survival and a better quality of life. Your body will recognize the kidney as a foreign object not present at birth, and as such it will attack it by all means possible. This attack is called rejection. Your body tries to reject the kidney. Now, rejection goes against all the purposes of transplantation, and as such we need to avoid it. To avoid rejection, you will need to take for life medications called immunosuppression medications or anti-rejection medications. There are medications that modulate, that suppress your immune system, which is accountable for the rejection. Unfortunately, these anti-rejection medications are not, let me repeat, are not kidney specific. We don't have a medication that will tell your body, leave the kidney alone, but keep on performing all the other activities that the immune system, that the defense system performs. As such, there are potential complications associated with immunosuppression, potential side effects, that is, potential unwanted effects. These side effects include, but are not limited to, the following. First of all, you'll be more prone to infections of all types with fungi, bacteria, parasites, and viruses. We have to make sure that you're covered against these infections. Second, you'll be more prone to malignancies, to cancers. of all types, especially skin cancers. We recommend that you see a dermatologist, a skin doctor, every year to have yourself checked for this. Now, given these findings, we need to make sure that your immunosuppression levels are high enough to prevent rejections, but low enough to minimize the side effects. As such, we go on a continuous equilibrium among both based upon your specific needs. Some other side effects of the medications, including immunosuppression medications or anti-rejection medications, is damage to the kidneys. As such, we need to always make sure that we monitor your levels very closely. Let's speak about the transplant process itself. It's a major surgery in which we usually perform an incision on the right lower part of your abdomen, but we may need to go to the left. We sew the kidney to the artery and vein that go to your leg before they reach the leg, of course. The artery and vein that go to your leg start where your belly button is, and then they divide into right and left. We will not, in most cases, let me repeat, in most cases, we will not remove your native kidneys. We leave them in place. Many times we don't even see them. Most of the time, I should say, we don't even see them. So if you had 2 kidneys to start with, at the end of the transplant process, you will have 3 kidneys, counting the transplanted kidney. After sewing the artery and the vein, we sew a little tubing that comes from the kidney called the ureter, U-R-E-T-E-R, ureter. We sew it to the bladder so you can pass urine in a normal fashion. And subsequently, we close the muscles to your abdomen and the skin. Please be aware that although most cases evolve in a way without any complications, there are potential complications that we need to consider. The most frequent potential complications include, but are not limited to, the following. First of all, there could be infections, requiring us to open the wound or to place tubes in the tissues around the kidney. Second, there could be bleeding, requiring for you, if you accept, to receive transfusion of blood products, or to have to wash your abdomen a bit as well to remove any potential clots that we think need to be evacuated. Third, there could be injury to other organs, such as nerves or organs within the abdomen. There could be injury to blood vessels, such as the artery and the vein, that may require us to do further surgeries or to have other specialties involved. There could also be injuries to nerves that could produce sensory or motor complications. Now, on very rare occasions, we may encounter very rapid rejections that may potentially cause the loss of the kidney, or we could encounter clotting of the kidney. For various reasons, the artery or the vein may clot. In most cases, if this is the case, we would lose the kidney. We would need to remove the kidney. They tend to occur soon after surgery, these clotting complications. Or we could find narrowings of the arteries or the veins that could require us to reoperate on you or to have to perform other tests, such as angiograms, putting a bit of dye in the arteries or the veins to see what the injury there is. And sometimes we may need to fix them, to repair them surgically, or by means of interventional radiology, putting some tubings called stents that will help us to keep the narrowings, the strictures, patent. Other type of complication, and this tends to occur frequently, or relatively frequently I should say, is that there is urine leaking internally from where we saw the ureter, the tubing that comes from the kidney to the bladder, or there could be, rather than a leaking of urine, a narrowing where we saw the ureter to the bladder. This may or may not require any interventions, such as placing of tubing skull stents or additional surgeries. Please be aware that you will require a very close follow-up after the surgery, after the transplantation. We need to monitor your levels of immunosuppression, of anti-rejection medications. We need to monitor your kidney function. We need to make sure that we don't detect any infections. Sometimes there could be some neurological side effects of the immunosuppression medications that may require us to change some medications. Please be aware about these potential complications, that such complications could diminish or totally cancel the benefits of transplantation, such as a prolonged survival and improved quality of life. Let's address now the types of kidneys that we could receive. Though all the deceased donor or cadaver donor kidneys are graded on a percentile scale called KDPI. They're graded and according to the percent, we know that they have a predicted outcome which is better or worse with respect to a baseline. The higher the percent, the more likely it is that the kidney will have some type of problem. To accept kidneys whose KDPI percentage is 85% or higher, we will ask you to sign a special consent form. The benefit of obtaining these kidneys, although you may think that they have a higher incidence of complications, is the fact that you could potentially be transplanted sooner and may require less time on dialysis. There is another type of kidney division called the increased risk CDC type. CDC stands for Centers for Disease Control, in which these are kidneys that have been procured from individuals who were exposed to high risk activities according to the CDC, the Centers for Disease Control. These kidneys tend in general to come from younger individuals who are engaged in such activities. The activities described as a high risk include, but are not limited to, having used intravenous drugs, having been incarcerated within the past year for more than a few days, having been involved in exchange of sexual activities in exchange for money, drugs, or other compensation, and other activities. It doesn't mean that it will acquire any infections. I mean, the main risks within this are various pathologies and infections, especially hepatitis B, hepatitis C, and the HIV/AIDS virus. We test all these donors, and if any of these ones were positive, we would let you know. But we test them, and although the tests are negative, there's sometimes a window period in which the test may be falsely negative, in which the person has acquired the infections, but the test does not detect it early. The risk is relatively small according to some studies. The risk of acquiring such infections is 1 in 30,000. Again, 1 in 30,000 cases. Other publications have different numbers, but that's according to one of the currently available publications. On some occasions, especially with deceased or cadaver donors, but also with live donors, the kidney may not start to work immediately. This is called delayed kidney function or delayed graft function. And you may require dialysis for a period of time ranging from days to weeks to months. Unfortunately, it's impossible to predict in advance what this period of time would be. In very rare occasions, the kidney may not work at all. Now, there are two types of donors that we have to keep in mind. One is, as we mentioned before, cadaver donors, people who have died, who during life have agreed to donate, or who, after death, the family agrees to donation. The other type are the live donors, individuals who agree to donate one of their kidneys. When you compare both groups, live donors tend to do much better than cadaver donors. So we highly encourage for you to let people know that you need a kidney so people can volunteer to give you one. Keep in mind, please, that it doesn't matter how good a person is, unless they know they can help you, they will not offer. Not because they don't want to, but they need to know that they can help you. And it's up to you and all those with you to let people know. The live donors could be a friend, a relative, could be a male, could be a female. They need to be 18 years of age or older, and by federal law, they cannot be compensated for doing this. That is, you cannot pay them or give them anything of value in exchange for giving you the kidney. It has to be a voluntary act. The wait time for a cadaver kidney in the state of New York is one of the longest ones in the country. It ranges between 5 to 8 or 9 years. Please be aware that you can list at different locations, not within the metropolitan New York area, but at different locations at other states, and sometimes within different states at several locations. This may allow you to have a shorter waiting time. But please be aware that overall, live donors do better than cadaver donors and deceased donors. And if you have a live donor, again, if you have a live donor, the time we need to wait to perform the transplant is as long as the time it takes for us to do the full evaluation. For you to be aware, although there's a risk with any surgery, the live donor surgery, it's a relatively safe surgery. We evaluate potential live donors very thoroughly, and if it's not safe for them to donate, we would not allow them to do so. Live donors do not need to take any medications associated with a live donation afterwards. They can continue with their normal lives. After the transplant, it's possible to have children. We recommend that before you decide to engage in a planned pregnancy, if it's an unplanned pregnancy, just tell us, and we'll adjust the medications. But if it's a planned pregnancy, if you could please tell us 4 to 6 weeks in advance of the pregnancy, so we can change some medications that cause birth defects. Please be aware as well that the risk of tumors, of malignant tumors, of cancers, is higher in the native kidneys, in the old kidneys. And as such, we recommend that you have an ultrasound of the native kidneys every 1 or 2 years to make sure there are no lesions. We also have to remind you that since you will be taking immunosuppression medications, you should consult with us before taking any type of vaccination, and you should consult with us in case you're exposed to any childhood illnesses or anybody with any illnesses, so we can determine how to proceed and what the best treatment, if any, should be. Also with children who have been vaccinated, certain vaccines will require you to be kept from a distance, for example, without changing the diapers of the children for a few days. A couple of final comments to put this together is please keep in mind that transplanted kidneys do not last forever. Live donor kidneys last longer than deceased donor kidneys. When you put both of them together, on average, they last about 13 years. So in many cases, please be aware that you may require a second transplant later in life, since we expect you hopefully to live much more than 13 years. Another point that I didn't mention previously is that in instances of diabetes, when you're diabetic before the transplant, the medications that we give, the immunosuppression medications, will worsen your diabetes. So you will require either more insulin, or if you were not on insulin, you may require insulin, or a greater dosage of medications to control the diabetes. If you're not diabetic, please be aware that 1 out of every 4 individuals who receive a transplant may or will become diabetic after transplantation, in some cases requiring insulin. But overall, we have to let you know that if your body is strong enough to receive a transplant, if we think we will be helping you, transplantation provides 2 main benefits. It improves your survival, and it has a beneficial effect on your quality of life. We look forward to meeting you personally during the evaluation process.